today we're going to talk about examining the thorax and the lungs. So usually what we do is we get the patient to sit on an examination bed and we examine the posterior and the anterior chest separately. So usually we start with the posterior chest. So you sit the patient on like the examination bed with their back facing towards us. So we do the same sequence as all the bodily systems. So we do inspection, and then we do palpation, percussion, and then we do auscultation. So in terms of inspection, so you basically expose the back of the patient. You either take their shirt off, but cover the front. Anything that you're not examining, you have to drape, by the way. So if you're examining the posterior chest, make sure that the front chest is covered. So you inspect the posterior chest. So what you look for are, obviously the spine needs to be like down the midline. Any asymmetry that you could notice, that is very important, obviously, because like, for example, if there's like any asymmetry in terms of breathing, then that could indicate something like, I don't know, pleural effusion or something. So so the spine has to be midline. Any asymmetries in breathing or just the general structure, any deformities in the chest, any traumas, any scars, any bruising or ecchymosis, any erythema, reddening of the area, like the general color. Is the patient pale or yellowish skin would indicate jaundice. You have to look at the size and shape of the chest. So the AP diameter, so the depth of the chest versus the lateral size of the chest. So this is called the AP diameter, anterior-posterior diameter. So that has to be less than 0.9. If it's more than 0.9, then this is technically called a barrel chest. So we see this in patients with COPD, for example. And the thing is, as we age, the AP diameter gets bigger and bigger anyway. But if it exceeds 0.9, then that might indicate COPD. We also need to look for any breathing difficulties. So if the patients are in some obvious signs of respiratory distress, so if they're retracting, for patients with severe asthma. So retracting is like when the patient is struggling to breathe, the areas like between the ribs get they sink. So that's called intercostal retraction. This can also be observed like in the neck. So this area, I can't do it because so this area between the neck and like the clavicles here, that sinks if like a patient with asthma is really struggling to breathe. So this is called the suprasternal retraction. So that is an obvious sign of respiratory distress. Obviously, if the patients are using any other accessory muscles for breathing, then that indicates that they're, struggling to breathe. Also, if they're tachypnic, if they're breathing really, really fast, we need to pay attention to audible sounds that might indicate they're struggling to breathe, like wheezing or stridor. So stridor is a very high-pitched inspiratory whistling sound, which is usually an indication of an upper airway obstruction. And this is, by the way, a medical emergency, so we need to really pay attention to these abnormal breath sounds. I forgot to mention, for inspection, what you actually do is when the patient sits in front of you with their back facing towards you, you can ask them to cross their arms like this and try to reach the shoulders like that. And what this does, it pulls the scapula out and it opens up the back basically. So you have a very good view of the posterior chest that way, instead of their arms just like on the side. But obviously some patients can't do this because of the limited range of motion. So it's okay if they just cross their arms in front of their chest like this. They don't have to literally reach for the shoulders, but that's the ideal position. So in terms of palpation, there's 4 areas that we need to palpate. So there's 1, 2, 3, and then lateral as well. So what do we need to palpate for? So firstly, we need to palpate for any areas of pain or tenderness. So we do that and ask them, is there any pain or tenderness in these areas? And then we palpate for chest expansion. So you place your thumb on the 10th rib, kind of parallel to the lateral rib cage, And you ask the patient to take in a deep breath in and then out. So when they inhale, because their lungs are getting filled with air, the rib cage should expand, right? So the distance between your two fingers should move out. And then as they exhale, move down. So what we're looking for is we're looking for symmetry. So they have to move symmetrical. So if this moves and this doesn't, then that's an asymmetry. So we assess the symmetry and we also assess the range of breathing. So the distance between your thumbs must move as they inhale and move back as they exhale. So we assess the symmetry of this movement and the range of the movement, okay? Any unilateral delay or decrease in the range of chest expansion may indicate something like pleural effusion or lobar pneumonia. So the third thing that we palpate for is something that we call tactile femitis. So tactile femitis, they are like palpable vibrations generated in our bronchopulmonary tree that gets transmitted into the chest wall as the patient speaks. So what you do is we use the ulnar surface of our hands. We place it on those 4 areas of the posterior chest, and we ask the patient, when you feel my hand touch your back, can you say 99? So 99, 99, 99, and 99. So what we're looking for are obviously symmetry between those pulsations that we feel, and we also note areas of high tactile femitis, low tactile femitis, and absence of any tactile femitis. Usually we would feel an increase in tactile femitis if the lungs are consolidated. So if there's fluid accumulation in the lung, for example, because that increases that increases the frequency of the transmission of the sound waves, basically. And we would feel a decrease in tactile femitis if there is a decrease in the frequency of the transmission of those sound waves. So for instance, we would feel a decrease in tactile femitis in an overexpanded lung. So for example, in patients with COPD or emphysema. So we move on to the percussion of the posterior chest. So there's usually 6 to 7 areas of the posterior chest, including the sides, the lateral sides, that we need to percuss. And we do this in like a step ladder pattern. So it's really hard to demo without a patient, but I'm gonna try. So imagine this is the back of the patient, and I get my pleximeter finger and plexor finger and I percuss. So this first area, and then I move on to the second one, and then this one, this one, this one, this one, this one, this one, that. And then I move on to the lateral, basically the sides of the chest. So percuss there, percuss there, percuss there, percuss there. So that's like 6 to 7 different like locations. And what you do is you compare again for symmetry. And normally, healthy lungs, they're resonant. So that's what you should hear when you percuss the lung. And this can be replaced with dullness if there is consolidation of the lung. So if the lung gets filled with fluid, or if there's like a mass underneath the surface. And you could hear just general hyperresonance if the lungs are hyperinflated, for example, in the case of COPD. So if there's unilateral hyperresonance, which means it's just on one side, then this might point towards a large pneumothorax. So after percussing those specific areas, we also need to percuss for the diaphragm. And this is to measure diaphragmatic excursion. What this means is basically just measuring how far or how well the diaphragm moves up and down as we take, inspiration and expiration. So the diaphragm is located around the 8th to 10th intercostal space. So that could be our landmark. So what you do is you ask the patient to take a deep breath in and hold it, and you percuss down to the lowest level of resonance, and you mark that area. And then you ask the patient to breathe normally and to exhale and to hold it there and percuss again downwards to the lowest point of resonance. And the distance between those points should be between 3 to 5 centimeters.